Our next speaker is Dr. Diane Portman. She's the Department Chair of Supportive Care Medicine at Moffitt Cancer Center. She brings a wealth of knowledge and will share models for innovations in palliative care to support an effective and resilient oncology care force. Dr. Portman?
Good afternoon. It's a privilege to be here. Thank you very much. What I really want to thank this group for is the amazing segues that allow me to sort of piggyback off of prior talks to talk about some of the things we've done at Moffitt. I'm going to give you some definitions of what we're speaking about so we can all be on the same page. Then I'm going to talk about when we invoke these various models and how and by whom. I'm using the National Consensus Project definitions from their guidelines that were just issued just a few months ago to talk about supportive palliative care in the 21st century. This is person and family-centered care, and what it deals with is relief from symptoms and the stress of any serious illness to improve quality of life for the patients and the caregivers. The way we do this is attending to the physical, the functional, the psychological, the practical and spiritual consequences of illness. The teams manage and assess pain and other symptoms, but also provide evaluation support for caregiver needs, care planning, and transitions of care going forward. The key to know is this is appropriate any stage of illness. This is not end-of-life care, though it may include that, for any age, and it's really beneficial in cancer care when it's provided alongside the treatments that are geared toward cure and life prolongation. What I think is becoming an evolving model in palliative care is that this should be a needs-based approach and not based on prognosis. There have been struggles to have palliative care adopted in institutions, and therefore many triggers were imposed. And these were automatic triggers, and they made a lot of sense, and many of them are still in existence. And there's been guidelines that talked about the early benefit of palliative care that said if we could do this, for example, within 8 weeks of any advanced cancer diagnosis, that would be superb. And there's elements of truth in that, but the reality of manpower needs, both in oncology and in palliative care, make that probably not doable. So what we're trying to do is truly identify needs in the newest approaches. That means focusing on what matters to the patients, their family, and other caregivers, and aligning our care with their stated goals, needs, priorities, and values every step of the way. This care has to be team-based. It must be interdisciplinary. There are core descriptions of the essential team members, including nurses, nurse practitioners, doctors, chaplains, and social workers. But as has been said many times, there are certainly other core team members that must be invoked. And we have to do that because there's a lot of different expertises required to render the holistic care that we must. The transformational vision for us is that palliative care principles and practice can be delivered by clinicians caring for oncology patients in any setting, not just by palliative care specialists. And we seek to have supportive and palliative care as in oncology as the fourth pillar of oncology care, alongside the essential disciplines of radiation oncology, surgical oncology, medical oncology. Therefore, all clinicians in all these spheres are encouraged to acquire at least basic knowledge and develop core palliative care skills. The way we've termed this at Moffitt is a new term borrowed from the geologic literature called intergrowth of palliative care and oncology. Call this, if you will, integration on steroids. And the concept from geology is that you may have beautiful functional crystals that stand alone in the environment, but they often insinuate and grow into each other and form a more functional and beautiful whole. And this is how we view palliative care and oncology, the growing together and through each other of the care components. Dr. Barrera from MD Anderson and his colleague David Wee have done a marvelous job talking about the hallmarks of this kind of intergrowth. And going clockwise, if we think about clinical processes, basically we must have access to the sort of needs-based palliative care I spoke of. That includes hearing the patient voice, and what that means is symptom screening in clinics and elsewhere, having clinical care pathways that embrace specified timing for referrals to palliative care, and referral criteria beyond just triggers. Invoking the guidelines that were alluded to earlier, like from NCCN and ASCO, and interdisciplinary palliative care teams that include oncologic practitioners, certainly the nurse practitioners providing palliative care, and concurrent oncology and palliative care treatments all the way upstream when needed. The program should be collaborative, and that includes multidisciplinary tumor boards. You can't do any of this, has been said this morning, without a leadership vision that allows us to innovate and pilot the models of innovation and then implement what makes sense. And that includes program funding and staff expansion, and including palliative care parameters and reported quality metrics for the institutions. What we have sought to have happen at Moffitt is palliative care in oncology on equal footing, each separate departments, but collaborating very closely with endorsement by leadership to have this as equal services. The education is paramount. We have to raise the palliative bar in oncology for all providers, and the only way to do that is have continuing education and onboarding curricula that are very well established and routinized and incorporated to all new hires. So that's lectures and curriculums and rotations and conferences, and then formal assessment of the necessary competencies with established standards for gauging those. The clinical structure historically was inpatient palliative care consultation, and that's still critical, crucial. But what we always are trying to do is move everything upstream. At Moffitt, there is somewhere around 380,000 clinic visits per year in the oncology disciplines. Most of the care is occurring outpatient. That should be mirrored by palliative care. And since we're talking about palliative care as a core discipline within oncology, within those clinics, oncology clinics, we should see that as well. Multidisciplinary needs and embedding in oncology clinics is very helpful. We want to continue with inpatient palliative care, but also innovative televentures. So now much is being said about outreach via video conferencing and telephonic means and other new things that I'll be talking about to reach out to the oncology population, including palliative care. And then ultimately coordination with community-based teams, because not all care happens in the centers. So connecting with hospice organizations that now not only have end-of-life care, but many external palliative care teams that also move upstream to consult in hospitals, and then payer-based funded palliative care programs in the community. So what's needs-based palliative care? It's care that's provided by the service most suited to the intensity of the patient's needs, and that can often be done within the primary oncology teams. We know that historically that's where all the palliation was done. And in this arena where we have both shortages of workforce for palliative care professionals as well as oncology care professionals, we want to think, where is it that palliative care is best provided? Sometimes you absolutely need specialty services for advice and recommendations, but the primary team can be quite capable if given that sort of training and onboarding that we talked about. And for a very small proportion of patients, actually, does the complexity of the symptoms warrant true specialty level palliative care. Patients can fluctuate and move in and out of different levels. We should be using instruments that are validated to gauge the need and screening constantly. This is a demonstration of needs-based palliative care in a pyramid form adopted from Palliative Care Australia that has written much about this. And of course, the base of the pyramid is where most of the care happens within primary teams, radiation oncology, medical oncology. Intermediate needs might be dealt with a 1 or 2 time palliative care consultation. High needs with shared co-management by oncology and palliative care, and then the complex needs at the tip of the pyramid that may require specialist level palliative care. So the challenge has always been, how do we get people not to recognize the need, because I think that's recognized, but how do we adopt and adapt the services culturally in different institutions? We want to seek that intergrowth. So how do we standardize that needs-aligned palliative care at the right times to gain the quality we seek? And how do we engage all providers in this endeavor? Well, the Oncology Care Pathways at Moffitt, which are proprietary and internally developed, are the way we have found to provide a very concrete direction for pathway-driven palliative care at critical junctures. These pathways actually change practice and culture. because they're informed by very specific tenets. And that's not what can I offer the patient among the array of things that I have, but it's what is best for this patient at this time. There's so much said about personalized medical care. And in oncology, that's the genomic and molecular aspects of care. But in palliative care, we want to look at the patient factors rather than physician preference or any scientific means. The treatment plans are in these pathways determined by the clinical presentation, the disease state, and always patient and provider decisions all the way along the line. They provide consistency of care because they're not recommendations or guidelines. They're actually very set, routinized steps that are defined and narrow. And since they're developed by consensus among oncologists and pathway specialists and palliative care professionals, we get buy-in and increase of awareness all the way along about what is best practice, and it encourages constant discussion. At Moffitt, we gauge adoption and adherence to the pathways as a performance metric. And what we have found is that outside of the pathway, we are getting already so much early adherence just because of the process of building the pathways together and the level of awareness and understanding that that has created. These evidence and needs-based palliative care pathways permit strategies that are symptom-based and used as high alerts. They prompt the very important deep conversations, the hard talks, that help us help patients and caregivers plan ahead and receive treatments that align with their goals. And overall, they improve the intergrowth of palliative supportive care the way I described it. Secondarily, because they're improving care and reducing variability, costs also decrease healthcare utilization. So an example here might be, say, a lady with advanced ovarian cancer. She moves through her pathway prompted by our EHR. All the way along, we're doing symptom screening, and we are prompting interventions toward those symptoms and concerns. And then somewhere along the line, perhaps she's platinum resistant and she has disease recurrence, and then we get, based on our consensus view, supportive and palliative care invoked. The care is multidisciplinary and comprehensive. It has all kinds of interventions from diagnosis to end of life, including evaluation and management steps, and always including up-to-date literature references, including from the palliative care literature, and cost considerations. This is how it looks in an EHR screenshot, because our pathways are driven through the EHR, customized between us and our EHR provider. Say a person with non-small cell lung cancer with a superior sulcus tumor that was not removable, a terrible performance status, now gets a prompt for a social work consult and supportive care clinic appointment. Much has been said today about patient-reported outcomes, and I really want to talk about the fact that while research can be informed by these, we have sought to take these outcomes as the voice of the patient and act upon that voice. If we're going to cure or prolong life with compassion, we must attend to the patient's concerns outside the disease and its treatment from their perspective. That means getting direct reports from patients and caregivers of how they feel now and provide the accuracy we need without us interpreting what that means. That improves our shared decision-making so patients get the treatments they want based on their tolerances, needs, and priorities and values. These kinds of PROs focus us toward what actually needs attention, and it helps us address effects of the disease and the medical treatments on the patient's well-being in real time. So here's what we've done at Moffitt. This is a well-known, long-established symptom assessment tool called the Edmonton Symptom Assessment System. It was always done on paper. It's a number of symptoms with a 0 to 10 scale, and patients come to our clinic in every clinic visit rate all these symptoms and how they're feeling. We sought to make that easier and flow into our EHR, so together with IT, our team developed an electronic, ESAS is the acronym for this tool, app. And this is a screenshot example for nausea. This is tablet-based. It's done in the waiting room or in the clinic prior to each clinic visit for any patient. And it has a small definition, like this is for nausea, are they queasy, and the patients rate it. When they do this, all the different symptoms flow immediately as vital signs into our flow sheet in our EHR, and they're scored like a lab value. If they're high in the severe range, it's denoted as such with color coding. we can then trend all the scores and follow them over time. And we did a study that showed that our level of documentation of these symptoms and the interventions rapidly for this really improved dramatically over time. But what about outside the clinic? We know that most of the patient experience happens between the clinic visits at home. So we have to have some kind of connection between visits, because what we know happens, patients in crisis, they wait, they call, they may have some trouble getting attention in a timely fashion, or by then they're now landing in an ER, urgent care center, or having what we wish could have been avoided as an admission. We need digital solutions that incorporate their voice at home to inform the care throughout the journey. And that means attending to the symptom management, all the psychosocial behavioral needs, getting that right care at the right time, anywhere care. And we know that there are apps for this as well. So I don't have any disclosures to make. I'm just going to give you one example of an app that we like a lot. And it basically uses a word cloud technology to present symptoms and medication side effects to the patient. It's totally customized to their disease state, and huge amounts of information can be collected very rapidly just from a few taps. It has machine learning, so it's iterative, and whatever the patient reports as symptoms later get represented to them, and they can add new symptoms, so that constantly you have a constellation of a description of the patient experience looking for alerts, progressing symptoms, and management tips. We have very sophisticated algorithms in this to look at emotional and physical issues, some behavioral medicine issues, both the negative and positive symptoms, how severe they are. And this helps us predict who needs help now. This is followed as a triage page to clinicians in the clinic who have a panel of patients they follow in real time with this data that can come through. And Dan Diagnosis here is looked at in terms of his scale of well-being, his overall risk score, and decisions are made about who needs care now, who gets called now. Everyone prioritized by alert, severity, and risk, asking why is this patient a high priority. There are other televentures that we've adopted, and we've written about this. And we know there are marvelous ventures in oncologic and in palliative care together that address symptoms, help reduce patient travel burden, and thus spare costs, some of that financial toxicity we talked about, particularly to patients with very impaired functional status who don't travel easily. And those studies that have been done on this show very high satisfaction and improved comfort, not just for patients, but for their caregivers as well. We asked ourselves, how could our telehealth venture support other priorities for patients with cancer who may now have great functional status for a time? So we know that with all the new oral therapies in cancer and the improved survivability that was talked about this morning, we have patients who often really want to move down some aspects of their bucket list and do things they never could have done when they were tethered to an infusion center. So we said, how can we promote seeking meaning for these people and do some of the other work of palliative care and oncology, which is legacy making and dignity work and finding out what's important to people and help them create treasured memories for their families with photos and videos from their travels. So we engaged in a venture to facilitate legacy making and dignity work. Our staff was so inspired by this. You talk about resiliency in the work. It's this sort of thing that makes people want to go to work, and we did this as a team. We also engaged in innovative team-based clinic care, and I want to talk to you about one such team venture called our Vitality Clinic that was a direct result of what you heard about this morning, the NCI ASCO Teams in Cancer Care Delivery Project in 2016. We were part of that study, and our Vitality Clinic, which deals with patients with cancer, anorexia, cachexia as a team-based shared mental model approach, was the result of that. We continue to refine it. It's rolling along very well. It basically took care for this very important entity of appetite and weight loss that was completely fragmented and causing a lot of distress to patients and caregivers, and consolidated an approach based on the shared mental model in one location with all the disciplines, with patient and caregiver right at the center to inform that care. Nutrition, rehab, and supportive care. Our APP effort is ever expanding at Moffitt, and we have 1.2 APPs per doc now, and this is an ever-growing phenomenon along with our pharmacy approach as well. So to summarize, collaborative care innovation models for intergrowth of need-based palliative care and oncology include pathways, various digital solutions, unique televentures, and team-based care. Thank you so much.